compensatory physiological responses in heart failure. The compensatory mechanism. Consequences of heart failure. When you have a cardiac failure, venous pressure is increased, cardiac output is decreased, which decreases BP, and increasing in sympathetic activity, which will decrease renal blood flow. Renin-angiotensin system will be activated, and increase in renin-angiotensin 2, increase in aldosterone, and increase in sodium and water retention, which will cause edema. And when venous pressure is increased, capillary filtration is increased and edema. Cardiac output decrease will cause natriuretic peptides increase and natriuresis and vasodilation. Now, increased sympathetic activity, activation of renin angiotensin aldosterone system, activation of natriuretic peptide, and myocardial hypertrophy. Now, acute decompensated heart failure. When compensatory mechanisms restore cardiac output, heart failure is said to be compensated. If these mechanisms fail, heart failure is decompensated and patient develops worsening signs and symptoms. Therapeutic strategies. Now, therapeutic strategies. Chronic heart failure is managed by fluid limitations, low dietary sodium intake, treatment of comorbid conditions, and use of diuretics. Now, drugs can precipitate or exacerbate heart failure such as NSAID, alcohol, non-dihydropyridine calcium channel blocker, and some antiarrhythmic should be avoided if possible. Inhibitors of renin angiotensin aldosterone system. Now, angiotensin converting enzymes. You know this angiotensinogen converts to angiotensin 1, and ACE enzyme converts it into angiotensin 2. ACE inhibitors work here and blocks this mechanism. ACE inhibitors will decrease the circulating levels of angiotensin 2 and inhibit degradation of bradykinin, which has the 4 major effects shown. What happens here? ACE inhibitors, degradation of bradykinin. So levels of bradykinins will increase, and decreased preload and afterload and increased cardiac output. Angiotensin 2, what was its work? Output of sympathetic nervous system is decreased, vasodilation of vascular muscles is increased, and retention of sodium and water is decreased. These are the effect of ACE inhibitor. The reduced retention of sodium and water results from 2 cases: decreased production of angiotensin 2 and aldosterone. Angiotensin 2 is decreased because you have inhibited here. ACE inhibitors will work here and will also work here. So you see, these are all the mechanism of ACE inhibitors working. Actions are decreased vascular resistance afterload and venous tone preload, resulting in increased cardiac output. Therapeutic uses: symptomatic HF-REF. ACE inhibitors are indicated for with all stages of left ventricular failure. Start at low doses. Pharmacokinetics: absorbed orally. Foot may decrease absorption. They are prodrugs and require activation by hydrolysis via hepatic enzymes. Adverse effects: postural hypotension, renal insufficiency, hyperkalemia, persistent dry cough, angioedema. Now, angiotensin receptor blockers, ARBs. They are orally active compounds, competitive antagonist actions. Their actions are on preload and afterload. Pharmacokinetics: they once daily dosing, valsartan, losartan. Elimination through urine and feces. Adverse effects: have adverse effects similar to that ACE inhibitors. And ACE and ARBs both are contraindicated in pregnancy. Now, aldosterone receptor antagonist. Patients with heart failure have elevated level of aldosterone due to angiotensin 2 stimulation and reduced hepatic clearance of hormone. Spironolactone and eplerenone are antagonists of aldosterone at the mineralocorticoid receptor, thereby preventing salt retention and myocardial hypertrophy. Spironolactone has affinity for androgen and progesterone receptors, and so endocrine related adverse effects such as gynecomastia and dysmenorrhea has been observed.